Thank you, Tim. I'm sorry we've had such sound problems with Dries because he's got such really good information. I was going to say sound information, but that wouldn't have gone down well. I'd like to hand over to Tim Hardcastle, who's a surgeon in Corsi Albert Lutuli, also has a big interest in snake bites and has been a mentor to many people who have required assistance in managing their snake bites. If Dries manages to sort out his sound later, either we'll record him at another opportunity and get it off to everybody, or we'll bring Dries back. But we are going to have a few minutes of question and answer after the session with a panel from NSAG. Go ahead, Tim.
Thank you very much, Mandy. It's a very good opportunity to share with everyone. And as you heard, I'm a surgeon, but that doesn't mean I like to cut all the time. And as a trauma surgeon, I'm also an intensivist. And as such, you know, it's important to understand that, as Dries almost told right in the beginning, most snake bites are non-venomous. So there are some that can cause a bit of tissue damage, you know, big python, and there are South African pythons around, and some people keep them as pets. If they bite you, they have quite nasty teeth, and they can make quite a bit of damage to the soft tissues, but without causing tissue necrosis generally. And the same goes with a large mole snake. Now, just as a matter of principle, I'm kind of discussing the issues beyond the emergency department. So one of the issues is that all significant bites should at least have 24 hours of admission, even if that's just for the sake of observing the patient, not necessarily for giving them antivenom. So in terms of ICU care, this is mainly for the neurotoxic bites, and particularly the neurotoxic bites from the black mamba and the Cape cobra are the ones that require ICU care in the main. For that, you require an early definitive airway because of all those P's that were mentioned by Dries just before he got into the sound trouble. And then once they're intubated, they need to have appropriate lung protective ventilation. Once they've had their antivenom, they generally are able to wean from the SIMV to a pressure support mode and extubate and so on fairly quickly. Very seldom that you need to do a tracheostomy in a snakebite patient, and certainly not in those with neurotoxic bites. Occasionally, we've seen a lot of tissue necrosis around the neck, and once we considered doing a tracheostomy for a child who had a Mozambican spitter bite to the face. Unfortunately, the child demised before we got to that point for multiple other reasons, including renal failure. And if necessary, inotropes may be used, whichever you're comfortable with in your ICU. Now, Dries has touched on this, and I just wanted to re-emphasize pre-dosing with a 1/4 amp subcutaneous adrenaline. And I always make the point of saying adrenaline for prophylaxis, subcutaneous. Adrenaline for anaphylaxis, intramuscular. Adrenaline for cardiac arrest, intravenous. If you remember those 3 steps, then you'll get the right one, and the dose is different. So it's 0.25 for pre-dosing, 0.5 for anaphylaxis, and 1 milligrams for cardiac arrest. And as pointed out by Dries, there's no role currently for the use of steroids or antihistamines as part of prophylaxis. There is a role for it subsequently should the patient develop serum sickness and renal effects and so on. Certainly, this only happens around about 12 to 24 hours beyond antivenom administration. You'll notice the doses that he touched on are pretty much the same that I'm mentioning here. We err on the higher side with the neurotoxic bites, and with the exception of a gaboon adder who gets 200, we normally give between 50 and 80 also for the cytotoxic bites. The other group of snakes that need slightly higher doses, for some reason we find, are the northern Natal species of the spitting cobras, particularly Mozambican spitting cobra. The way that we administer it is to dilute in a 100 to 200 mils of normal saline, and that should be 30 minutes, not 3 minutes. Apologies for the typo. But there's no real difference whether you give it undiluted or diluted. It's just that you then have an intravenous access. Some of the other important things that people are inclined to overlook, both morphine and benzodiazepines have been shown in a number of studies to potentiate the venom effects of particularly the neurotoxic snakes. So for your analgesia and your sedation of these patients, we advise against using morphine and benzodiazepines. The preferential drug is intravenous infusion of ketamine for sedation and analgesia, combined with either intravenous or oral paracetamol. And in the patients who you want to consider non-steroidals, because yes, non-steroidals give you effective pain relief, but please not for the first 2 or 3 days, and make sure the patient's renal function is normal before you start them on non-steroidals. This sort of attitude of everybody with trauma getting a shot of diclofenac in the shoulder really needs to die a rapid death. Apart from the fact that it kills kidneys, it also kills patients, because we've seen a lot of patients with sterile abscesses. So please avoid the use of non-steroidals in the early phase. It switches off the function of platelets and of course is associated with worse bleeding. And interestingly enough, the couple of compartment syndromes I've seen have all been in patients where non-steroidals have been given. So here's the bunch of nasties that we come across: the puff adder, rinkels, in the middle, the 2 spitting cobras, the rinkels at the top, the Mozambican at the bottom. On the right at the top is the Berg adder, and the bottom is the night adder, or the other way around. I always get confused, but the one has got the classic V. The important with both of them is that there's no antivenom. And then that nasty little bugger with the back fangs is your stiletto snake that really causes the most tissue damage in small areas that may require some surgical intervention. So how do we deal with snakebite wounds? First and foremost, if you're seeing the patient acutely in the emergency department, wipe away the residual venom and clean the area, preferably with chlorhexidine-based antiseptics, or otherwise, if you've got good clean tap water, just use simple tap water. What you should avoid is the povidone or iodine-containing solutions, and certainly you should not be combining them with chlorhexidine, because the one is an acid, the other is an alkali, and you actually neutralize the effect of the two. In terms of assessing the wound, the time-honored TIME approach is the safe way to do it. What is the degree of tissue viability? Is the tissue viability already compromised? Are there inflammatory changes? And again, that's usually in the form of edema. Most importantly, as Blaylock's work has shown fairly clearly, there's usually no bacteria or not significant volumes of bacteria in the mouth of the snakes, and therefore to put them on antimicrobials is usually unnecessary. Moisture balance is important. So wounds that are wet and weepy and blistery are obviously going to be a challenge, but at the same time, we know that moist wounds heal better than dry wounds. And then what you want is an epidermal advancement. You want the skin to be closed over the defects once the tissue has been debrided. And don't forget, the wound is more than the wound. The wound is attached to a patient. And just like we try and teach the orthopedic surgeons that when a bone is broken, there's more to the broken bone than just putting a nail in it, the same applies here to the patient. You've got to assess the patient in terms of their comorbidities, their underlying diseases, their current physiology, and make sure that you undertake effective care of all of that. If they're known with chronic renal disease or cardiac issues, their risks are even far higher for tissue necrosis. One of the changes that's occurred over the last 5 or 6 years in the management of snakebite is the concept of actually deroofing the blisters and covering the underlying tissue with a silver-containing antimicrobial dressing, such as an Acticoat or a hydrofiber with silver, like Aquacel Silver, just to give 2 examples, and there's multiple different ones on the market. So take a sharp debridement, forceps, scalpel tip, and a pair of scissors. Debride the blisters back so that you have that clear area, and then put a silver-containing dressing on as the topical cover. I mean, this is generally what you're dealing with. You have a mixture of tissues with blisters, necrosis. Obviously, the bite here is on the foot. Areas of severe edema, and you can see where the blisters have already self-deroofed. So this tissue in the acute phase is where particularly plastic surgeons, but also general surgeons, see this and say, oh, it's dead tissue, I must go and cut it away. The short answer is no, not yet. Wait, let it demarcate. It's the one condition where you have to give time for the tissues to demarcate before you go and chop. Otherwise, you cut away tissue that's actually viable. So your acute wound care, silver-containing dressings are, like we do for burns, very, very important. You want to keep the moisture balance in the wound, so hydrocolloid and hydrofiber dressings are useful. Make sure that the antivenom is given before you start cutting away any tissue where it's indicated. Tetanus toxoid should be given, although there's never been any documented cases of tetanus as a result of snake bites. And then most importantly, you don't want to do any further harm, so avoid tight dressings. A light bandage to keep the dressings in place is all you need. And maybe even at some point the use of a negative pressure wound therapy. We'll talk about that shortly. So here's just an example of the typical stiletto bite. This is probably the bite in the cities that we will see the most. Okay, so if you see the time period here is about 3 weeks for the tissue healing. Patient presented to us with this big necrotic blister on his thumb. 3 days later, it had demarcated, and you'll see that we'd debrided the dead tissue, and the underlying tissue was a bit raw. We covered it with a silver-containing dressing, and 5 days later, we took that dressing off, and you can see that the underlying tissue, the wound bed, had now clearly improved. But you'll notice that the thumb and the rest of the finger was still rather black, but we just said we'd wait another 2 days, and you see that blackness had disappeared. A further 3 days later, the tissue was very nice and healing, and all we ended up with was this tiny piece of eschar on the tip of the thumb, which we debrided and took out just that little tip and allowed it to heal by secondary intention, and no skin grafts or anything were necessary for this particular wound. So this is a classic stiletto bite. Obviously, your bites from Mozambique and spitty cobras and the puff adders can be far more extensive. And this brings us to this issue of compartment syndrome. And yes, it does occur, but it occurs, as the guys in that video mentioned, far less than what it's made out to be. So one of the rules before you may do a fasciotomy for a snake bite is you must document in all 4 compartments below the knee or both compartments of the forearm that the pressure is excessive, and usually we take a cutoff of 40 millimeters of mercury for this, or a tissue perfusion pressure less than 30 millimeters mercury. So it's going to cause capillary compression. So you can use the fancy, expensive commercial device. The Stryker device is the one most commonly available. Alternatively, you can use an arterial line transducer and stick the needle into the compartment, and flush the needle, and then allow it to equilibrate and measure the pressures in the compartment. Alternatively, you can simply use a 3-way tap and a mercury manometer, which can directly measure the pressure. So in summary, no fasciotomy without measuring the compartment pressures, and also no fasciotomy before adequate administration of antivenom. With a bit of elevation and antivenom, 99% of the time the pressures come down and you do not require fasciotomy. So here's again another example in a child that had a more extensive bite, and this is the progression over the first 4 days. You'll see the blisters on arrival. We debrided the blisters, and you can see the underlying tissue 3 days later was still looking viable. And this is why you have to wait and watch. You'll see at day 7, the wounds on the skin of the leg had healed up very nicely, the bottom right photo. However, on the foot, there was black eschar, which required debridement, and at that stage, skin grafting. So some of the general principles. For the tissue viability, assess it using sharp debridement, so scalpel and forceps. Only cut back the essential dead tissue to healthy bleeding tissue. Make sure you have adequate hemostasis, so use a cautery. Be gentle with your tissue handling. In terms of the moisture balance, ensure that you do not dry out the wound. So if the wound is dry and escharous, you can use a gel such as Intrasite, or if you think that there's some dead tissue, you can do enzymatic debridement with something like Iruxol. Make sure that you use the most appropriate wound dressings. And as time progresses, if there's no healing coming up, then please consider using something like Promogran, because these wounds get colonized with tissue flora. So that you can either wash them with something like Prontosan solution, or you can put a Promogran dressing, which helps the dermis to regenerate. And then the one tool that we have that is developed over the last few years that's really, really useful is this vacuum-assisted closure, also known as negative pressure wound therapy. And you don't have to have the fancy commercial device, although if you're in the private sector, obviously these are available to you. But simply, once you've done your wound debridement, layer of Gelinet or Adaptic or some other non-adherent material. Again, there's lots on the market. These are purely examples. Some form of sterile sponge. 3M makes one called Reston foam. Alternatively, you can use gauze, layers of gauze. It works just as effectively. Cover it with an occlusive sticky dressing such as Opsite, Ioban, or Steri-Drape, and then literally connect a Celastic tube or a suction catheter under that Steri-Drape, and you place it on your normal wall suction via a regulator and aiming for minus 20 kilopascals, but you can go as high as minus 75. We know that negative pressure wound therapy improves vascular ingrowth. It sucks away any slough. It certainly removes microbes very effectively, and it encourages wound bed preparation, so that when you come to the point of skin grafting, the chances of your skin graft taking are far better. And thank you. That's basically what I have to say. I'm not going to go into the detail of how to do a fasciotomy, because as you've heard, for the vast majority of cases, the fasciotomy is unnecessary. And I think that's the take-home message. And as the Snake Shine says, well, we're happy to take some questions at this point. My contact details are there as part of the National Snakebite Advisory Group. Anyone's welcome to WhatsApp or contact me, alternatively via the group. And if you let us know which province you're in, we will direct you to the most closest and appropriate person. Thank you very much.
Thank you very much, Tim. I really appreciate that. Dries, are you back by any chance?
Hi, Manny. Yes, I'm back.
Was there something that you wanted to finish off with for the talk?
Let me see quickly. I think I was actually just talking about antivenom doses.
Okay.
And I was going to do 3 case studies, one on a neurotoxic bite, one on a cytotoxic bite, and one on a hemotoxic bite. And what I'll just say then is that, let me just mention this. When you have a patient with a neurotoxic bite, one of the little pitfalls is tourniquet release. So maybe I could just say something about that. I'm actually not going to put my slides on. In general, if a patient's got a tourniquet on, the patient arrives in your hospital, it's good practice to get the patient into your resuscitation area as you would for any snake bite, and then to release the tourniquet as quickly as possible, obviously to salvage the bitten limb and cause as little as possible tissue damage to it. But if you have a patient that comes in with a neurotoxic bite, a cobra bite, or a mamba bite, you should just be a little bit cautious about the way you do it. Because you can get something like a venom rush, especially if a person comes in with a mamba bite and that tourniquet has been applied maybe for, let's say, 30 minutes, 40 minutes, an hour, and you suddenly release the tourniquet, you can actually cause, venom and metabolic toxins to suddenly enter the circulation, and you can get a precipitous, deterioration of the patient. So what we do in those cases is we blow up a tourniquet above the tourniquet that's been applied. We then start running the antivenom in. And then we release that, that tourniquet that was applied while the tourniquet proximal to it is still on. And then that tourniquet that we applied, we gradually release to prevent a venom rush. So that's maybe something that people should just should be aware of when they deal with these kind of cases. I was also going to talk a little bit about ward observations of patients, and I just want to warn all of our listeners, all of the people that are here, that when you admit a patient with a snake bite, it's not something that you can just like put in a ward and assume that the patient will be fine. There's been a couple of medical legal cases where, especially in rural hospitals, where people have admitted snake bite cases to general wards, and then the next morning on the round, they discover that the patient is dead. And that's usually undiagnosed neurotoxic bites. And patients who are admitted with snake bites must have close observations. And things that help is regular evaluation of the saturation of the patient, doing a blood cast on the patient and repeating it after an hour or two, doing things like peak flows, because you can see a deterioration in the peak flow, and then obviously all the normal vital signs in the GCS must also be closely observed. So you're almost talking about high care observations when you admit a snake bite case. So that's just something that I also was going to mention. I think that's the most important things I wanted to say. I wanted to say one or two things about the long-term effects of snake bite. And that's something that's not often discussed in these kind of forums. But remember that, there's a lot of long-term effects, wound effects. Patients who get wounds needs to be placed, for example, under the care of a wound care team, because some of these wounds can take a long time to heal, and they need special care, repeated dressings to prevent them from becoming infected. Sometimes when there's amputations involved, people need to be put in contact with people who can make prosthetics. So that's a part of the long-term management. Serum sickness is something that patients sometimes develop 7 to 10 days after getting antivenom. And they usually get pains, and in all their joints they get fever. So it's something that people must be aware of, and it usually resolves also with a course of steroids. Another long-term effect is obviously the psychological effects it has on patients. They can develop post-traumatic stress syndrome.
Sorry, Chris, it's Mandy.
They can develop a lifelong, hate for snakes and want to kill the snakes they come across. So sometimes they need counseling to deal with those kind of long hits.
Chris, I'm sorry, can you hear me? Tim, see if you can get hold of me.
Yeah, I mean, that was just some of the things that quickly come to mind.
Address, you were going to address the issue of neostigmine. I gave some of that information in my talk, but yeah, you didn't mention neostigmine. Do you want to address the neostigmine issue?
So Tim, I have muted Dress because we can't hear him. It makes it a very difficult webinar to have. Do you want to mention something on neostigmine, and I'll phone him again?
Sure. Okay, so neostigmine has a role in certain of the neurotoxic bites. Now, the important thing about neurotoxic bites is they affect two different parts of the synapse, the presynaptic and the postsynaptic component. And the neostigmine only works in the one component. And I always get confused personally with which is which. As far as I know, it's the presynaptic. And that is what you find specifically with the Cape cobra, the snouted cobra, and the forest cobra bites. It is with their venom, the mamba bites work on the other part of the synapse, and so neostigmine has no role in mamba bites, but does have a role in improving the neurological function in patients with the cobra bites. So I just wanted to get that clarity from him. He'll be able to tell us the detail about which synapse is involved. It's too long ago in my reading.
Thank you, Tim. Dress is having a terrible storm in that area, so he's battling at the moment. I think there are some people from NSAG on the group. I will unmute Dress again if he can hear us, but he says his sound is really bad. There were some questions around the use of South African polyvalent antivenom outside Africa, and I think the answer was that that you could do that because, especially in Africa. But the further up you went, sort of towards Egypt, there would be a problem using that. Is there anyone else who wants to take that question and just answer? Theo asked that question.
I don't know if Arnu or Jason or Johan Marais, they are the guys that know far more about the details of what works where.
Chris, do you want to address that now that you're back? Okay, Arno is not listening to us. Now there is Jason. I think some of the questions sorry folks, seems like my connection is very poor. Says Dress, I hope I can assist another child. He is going to leave. Anybody who wants any information with regards to snakebite can contact either me or Tim or Dress, and we will put you in contact with the right person on the NSAG group. So the National Snakebite Advisory Group extends into Swaziland and other areas, and we're more than happy to put you in contact. In fact, sometimes you just send a picture of the snakebite or a picture of the snake, and we're able to assist you. So please do not hesitate to contact any of us, and I'll send a list out to all of you of who's on the NSAG group so that you can contact. There's a guy by the name of Arnu and a few others that are very good at identifying snakes, even identifying bites, and they're extremely good. Chris, this one on the exotic venomous snakes, cottonmouth, we have suppliers of these that any of the zoos that keep these have to keep antivenom, and one of the big zoos is the one in Hartbeespoort Dam. So we do get it, except it's hellish expensive, but it should come through NSAG as well. Are there any other questions? Dress, are you back?
Yeah, Mandy, I'm back. Sorry about my bad connection, man. Yo,
No, that's fine.
Afton dealt with the issue of neostigmine.
Yeah, he just wanted you to deal with.
Yeah, I just wanted you to
typical.
clarify which one is the presynaptic and which one's the postsynaptic. I did say that you can use it for the cobras, but not the mambas. But I said you'd address the technicalities of what part of the synapse it works on.
Yeah, you're absolutely right. No, look, I mean, you know, the black mamba has got presynaptic effects. It causes a lot of release of acetylcholine, and that's why you see it's also got a venom called fasciculin, which causes this release of presynaptic neurotransmitters, and that's why in mamba bites you often see patients fasciculating. And theoretically speaking, if you use neostigmine, it has a similar effect to that presynaptic effect, and therefore people are hesitant to use it in mamba bites because theoretically you can actually promote that presynaptic effect of the mamba venom, and sometimes you even get depletion of neurotransmitters, because the idea with neostigmine is that you give it and then it it prevents the breakdown of acetylcholine. So you get more acetylcholine in the synaptic cleft, which then is supposed to overcome the postsynaptic effect. But in things like mambas, where there's already a lot of release of presynaptic mediators, then you can actually sort of, get too much of it, and you can sort of make the situation a little bit worse. But it's more a theoretical thing, so we use it more for cobras then, and I haven't really used it for mambas, but some people have used it for mambas, and they say it actually does work. So that's the thing around neostigmine. It's something that's not like a miracle, but if you have something like not a very bad snouted cobra bite, and your patient might be just a little bit of ptosis, not really having a severe effect, is something worth trying. But it's part of a bigger plan, and you should know what you're dealing with when you use it. It's like it's like the reversal that we give at the end of anesthesiology for a full non-depolarizing muscle relaxant, and it pushes that muscle relaxants off the neurotransmitter, and it's something that you can try maybe if you have in various situations with neurotoxic bites, it has a role to play.
Thank you,
Thanks,
Dries. There's a question here from Bernard Siegel. Anything
Yeah.
the ED docs would like done by pre-hospital EMS crews?
So I think the most important thing is that the basics must be done right, and that applies. That's the whole point of tonight, is to make sure that the basics is done right. And from an EMS point of view, unless there's overt tissue necrosis, the most important thing is dress the wound, wipe away the venom, dress the wound, and use a relatively firm light bandage, not a tight constricting bandage. No tourniquets, no cat tourniquets, anything like that. Elevate the limb and then transport cautiously without making the patients tachycardic if possible, and pre-warn so that people can contact for advice sooner rather than later.
And Tim, I would add the right patient to the right hospital at the right time.
Absolutely. I mean, again, if you think it's significant envenomation, please check which hospital has got anti-venom and take the patient directly there. Pointless to take them to a little district hospital in the Bundus who doesn't have anti-venom, where you could have traveled for another 45 minutes and got the patient to definitive care.
Thank you. David Ogg's got a comment. I had a patient with a puff adder bite who presented predominantly with hemorrhagic complication, extensive petechial rash, and hematemesis. Bite was on the tarsal tunnel region of the ankle, assumed a predominantly intravascular envenomation, responded very rapidly to 7 amps of antivenom.
Yeah, there is a fair amount of hematological crossover with puff adders as well as with the Mozambican spitting cobras. They do both give some tissue necrosis as well as hematological effects. Unlike the monovalent, the worm slung bite, which predominantly gives you pure hemotoxic. And again, nobody's mentioned the 20-minute clotting test. So one easy test, and it becomes abnormal very early after the worm slung bite, is the 20-minute clotting test. So you take a tube of blood from the patient, you lie it on its side for 20 minutes, a red top tube, and if it clots, then I can almost guarantee you it's not a worm slung bite, or it was a dry bite. Whereas if it's not clotted after 20 minutes, start arranging your antivenom, and as Andreas said in his slides, it saves a lot of blood products later.
I just want to add to that, Tim. I actually agree with you, and I think it's actually one of the things I still wanted to get to is the 20-minute clotting tests, which is very, very useful test. It's also a way to differentiate between your puff adder bites and your things like your some of the severe other cytotoxic bites like night adder bites, because puff adder cause quite a bit of hemotoxic effects. Whereas things like night adders doesn't actually do it. So it's quite worthwhile if you have a patient with a painful progressive swelling to also do that 20-minute clotting test, because if it's deranged, it usually points to something like a puff adder.
Yeah, I see there's a hand up from Nat up here.
Yes, so as indicated in it requires an expert to identify a snake that is carried to the hospital. But in some cases too, it still requires expert to catch the snake or to kill it and then carry it as well. And so I think instead of spending so much time in killing the snake in an attempt to carry it to the hospital, we can discourage that and focus on bringing the victim as quickly as possible to the nearest EMS center. And then the other one I want to talk about is, as indicated again, some snake bites does not come with injection of venom. If those were the case, then we give enough information to the victim and then the family as well. This will help deal with the anxiety part symptoms to be identified. Then we can take over.
I think maybe I can just reply a little bit to that. Yeah, I agree with you that I don't think one must, spend time running after snakes and trying to kill them to bring them to the hospital to be identified. I agree with that. That's a good point. It would be helpful to if you've got a smartphone, to take a picture of it. It's quite possible to use the syndromic approach to treat patients without snake identification, but like I tried to explain, it can help if you know which snake bit the patient, because it can give you additional information on the management of the case.
Yeah, I agree. You don't want to go chasing after snakes, catching snakes. And you also don't want to delay getting the patient to appropriate care. People will have a second bite or a third bite from people chasing snakes. I agree with you.
The reality of it though is that many people get bitten when they are actually in fact killing snakes, and we don't get a lot of snake bites when people are not trying to kill snakes. So that's why we often find that people are bringing dead snakes, because it's usually in the process of trying to kill or interfere with snakes that they actually get bitten. And it's often snake handlers, people trying to catch snakes that are actually bitten by the snakes. And that's why we find that we sometimes get the dead snake or the captured snake with the patient. But, that's another matter. People should learn to just leave snakes alone, don't try to catch them. But, sometimes there's a snake, let's say, for example, in the yard, and people have seen the snake and they're not comfortable with the snake being in their yard, so they try to get rid of it. They try to catch it, and then in the process they try to kill it, and then in the process they get bitten. In that kind of scenario, it's good to know somebody in your area that can come and remove a snake. And there's a lot of people available. You can just contact the National Snakebite Advisory Group to give you advice, or you can find out who is your local person that does that, and then they usually come and catch the snake. They release it in a different area. Instead of trying to catch the snake yourself, try to kill the snake and then get bitten in the process.
Yep, that's very true. I see Ray Ellis has asked about pediatric dosing, and I agree 100% with what Andreas said. So to answer your question, Ray, when you're giving an anti-venom, you're dealing with venom to anti-venom ratio, not patient size. So there's an international paper that was published in Archives of Pediatrics this year, looking at an overview of evidence-based snakebite treatment. And the consensus in there was very clear from the World Health Organization. You give the dose of antivenom towards the snake, not towards the patient size. So if a child is bitten by a Mozambican spitting cobra, you give the same dose as what you would for an adult bitten by a Mozambican spitting cobra. There's no dose adjustment. I see John Bruce is on the group, has got his hand up. John, you want to make a comment?
Hi, Tim. Yes, thank you. I agree completely. The only thing I would say is that you have to be careful how you dilute it, because if you're dealing with neonates, you don't want to run into fluid administration problems. You have to come up with a strategy to give the correct dose, but bearing in mind that you might need to extend the time a little bit, because a massive fluid bolus in a neonate is obviously a bad thing. So that's the only caveat, but the dose has to stay the same.
If I can make maybe two quick comments. The first one is about this one of yours, John. It's, in Eswatini, they don't actually use a infusion at all. And so there is the potential of just giving the antivenom IV. When you do that, then you must just be cautious that you give it at quite a slow rate and don't push it in too fast to risk anaphylactoid reactions. But it is possible to do it like that. And I mean, they do it in Eswatini all the time, and they don't get problems with it. But you really have to focus on administering it slowly when you do it like that. And there's not a lot of neonates that get bitten by snakes, but it surely can happen. And I think that might be a place where you could look at doing it like that. One of the other things that I'll just mention, I see that you put a question here about venom in the eyes or venom ophthalmia. So that's something that we see with a lot with Mozambican spitting cobra bites. Basically, the principle is to rinse out the eyes with fluid. It could be any medical fluid. Ringers, lactate would be a good example, or water would also be fine. So just wash out the eyes. And then
you can even use milk.
The patient should all receive an antibiotic eye ointment. And in those patients where you find corneal ulcerations, so all of these patients should also receive like coloring, or a fluorescein staining of the eye to see if there's corneal ulcerations. Those patients should then specifically receive mydriaticums to dilate the pupil, to prevent synechia forming in the eyes. And all patients with venom in the eye must be followed up by ophthalmology to do slit lamp examinations to see if the eyes are recovering and if they need any additional treatments.
Thank you very much. I think everyone is battling a bit with storm, but it's been quite good. Is there anything else that hasn't been asked? Ray, are you comfortable now with the pediatric side of things? There's one message, maybe that's from Ray. He is happy with us.
Ray says yes. One other thing that was Liesl Taylor, who's one of the trauma surgeons in Cape Town, asked a question about the use of the hyperbaric oxygen. And yes, it is something that is postulated for wound care perspectives, but there's no hard evidence that it makes any difference. So if you have access to it, and certainly in the private sector, I'm sure they will have access to it, it is an option. I'm not sure how available it is in the public sector.
Just a quick...
Is it an option as wound healing, not an option of snakebite treatment? So it's that,
correct.
Long-term wound healing that you would have to address. Sorry, Dries, sorry.
Yeah, I just wanted to add on the point of tissue necrosis that people must remember to give Tetavax to these patients because, you know, they do get necrotic wounds, which becomes a good breeding ground for tetanus as well. So that's also just in the basic treatment of the patient. As of any laceration, it's important to remember to vaccinate them against tetanus. We've recently had a case again of somebody arriving in our emergency department. This was not a snake bite, but with a dirty wound who's not been vaccinated and developed tetanus.
Are there any other questions from anyone on the line? Just to, if there aren't any, just to say what a wonderful talk from both of you. Sorry about the sound problems. Dries, perhaps you and I could record this later on your side. So it would be a very nice talk for people to have. Tim and Dries, they are always available to help with snake bites, and you can use my number at any time. I'll put it over here if you need any assistance, and then I'll refer it to the group. Or you could use Tim or anybody else's. But here's my number in the meantime, and we'll refer that to NSAG, and NSAG will get hold of you or will give you the name of the guy in your region where NSAG will be able to assist you. Thank you very much. Oh, hang on. Last question from is it Ray again to everybody? Last question. Traditional treatments impact, do any traditional, I think that was Dean, do any traditional treatments impact snake bites, Tim? Or
the short answer is no, and they have no role.
Yeah, there's a lot of interesting traditional healer treatments. You know, they've got the so-called snake stone where they put a black stone on a snake wound, and then it's supposed to extract, the venom. Having the patient being bitten by a snake on the other side, so that sort of it will suck the venom from the one side of the body to the other side. So, I mean, these things are, not really obviously very effective, but I think the way one can involve traditional healers is to, there's a lot of snake bites that are obviously dry bites. There are a lot of snake bites that are by non-venomous snakes. And then obviously these things like snake stones and so on, they do work, but it's because it's not really a venomous snake. But I think the way to involve traditional healers is to sort of make them aware of the clinical syndromes, and so that they can refer these patients into hospitals when they do get that kind of bites. But none of these treatments are really effective. With traditional healers, there's also the idea that you can sort of try to prevent someone from being bewitched, and they often see a snake bite as a sign that someone has been bewitched. But I mean, I think it's more a question of working with your traditional healers, educating them. I've had a couple of traditional healers on my VAP courses. They actually respond to it quite well. And it's like many other medical conditions. If you can actually work with them and convince them to refer patients with more serious medical conditions and then treat the ones that are actually not as bad, then you can actually get a good working relationship with them.
Ray, are you done? I don't want to leave before you've asked another one. You cool? I'm sure he is. Thank you very much, Dries, again, and thank you very much, Tim, and to everyone who joined us. There were over 80 people on the talk. We want to reach a lot more people. We really believe we can do important work in the management of this epidemic in Africa. And it's also not COVID, which is really quite nice for a change. So thank you very much, guys. I really appreciate it. I will do the certificates in the next couple of days. If you just give me a moment till the weekend. It is CPD accredited, so you'll get your 2 points for attending this. So thank you so much. Be safe and look after yourselves. Bye. Don't play with snakes.
Thanks, everyone. Cheers.